That should give us plenty of time. I'm looking at 75, maybe 80 questions, 2 hours. That should be plenty of time.
Hi, Marie. I hope you have a good day.
Okay. There's a KSA on insulin posted for you on Blackboard. By tomorrow, there'll be a KSA on steroid therapy posted for you as well. We're doing endocrine today. We're doing orthopedics on Monday. And I almost have the burn lecture is almost done. I imagine that's probably going to get recorded and posted either tomorrow or Wednesday. I have 3 readings up on Blackboard, and all 3 of them are optional. The first 2 have to do with understanding and managing burn pain. And the second one is a little bit more historical that talks about the Coconut Grove nightclub fire in Boston, which was the turning point in burn care. And because of that disaster, we continue to do a lot of those interventions that were funded for the war in Boston and just put into effect because of the crisis. They're not testable, they're optional, but they might help you understand. And those of you from New England and the Boston area might find the 3rd reading a bit interesting. Okay, we're going to do something unique in 426 next semester. Because we didn't get to finish some of the things that I wanted to do because of time, we're going to convert those into group activities for 426. So Dr. Moran and I are going to be putting our heads together, and there'll be some kind of short voiceover lecture with collaborative group work done within your clinical group on clinical time in post-conference on things such as sepsis screening, treatment of sepsis, DIC, and environmental regional disasters. Okay? Mm-hmm. I'm working with Dr. Durham. We'll make sure that you guys have the same information, even if it means it's posted on her website or you get added to my website, one or the other. Okay? We'll make sure. We'll make it work for you. Okay? So today we're going to talk about endocrine. And in terms of your final, it is comprehensive, so there'll be some questions on cardiac and respiratory and neuro. The nitty-gritty questions, of course, will be on things that have not been tested yet, which will be endocrine and orthopedics. Okay? There you go. I was going to seize. And a little bit on burns. Burns is extremely complex care. It's the sickest of the sick. I don't expect you guys to know the nitty-gritty details of how to resuscitate and treat a burn patient. That's very high-level critical care. Whatever will be on the exam will be the basics. It will, and I'll say this during the lecture as well, size estimation, depth, what can cause a burn, topical treatment in general, pain management, risk of infection, smoke inhalation injury, and then the unique things that must be done for chemical burns and electrical burns. But the nitty-gritty, such as how to get somebody out of rhabdomyolysis, with electrical burn, that's not testable. It's information only for you at this level. Okay? So let's get started on endocrine. I'm assuming, and correct me if I'm wrong, this should not be the first time you've heard about diabetes mellitus. Okay? Let's hope not. Okay? I didn't expect it to be your first time hearing about orthopedics either, but we're going to manage with that one. However, if whatever I talk about regarding diabetes needs clarification, just let me know. But otherwise we'll go through this pretty quickly. There are 2 types of diabetes. One is diabetes mellitus, which is pancreas related. The other one is diabetes insipidus, that's pituitary related. We will be talking about both, but to start with, we're talking about diabetes mellitus. We use the term DM for this. And if you remember, there are 2 types. And every 20 years, they bounce back in terms. Right now, it's type 1, type 2. It used to be insulin dependent, non-insulin dependent. In practice, you still hear those terms intermingled. You may also hear adult onset and juvenile onset. But at the moment, the current terms are type 1 and type 2. Both have to do with failure of the pancreas to produce insulin in such a way that it is enough insulin and that it is effective insulin. Okay, so this is all pancreas related. In diabetes type 1, this is insulin dependent. Okay? The pancreas, for some reason, doesn't produce enough insulin. In some cases, it doesn't produce any insulin. This can happen pretty quickly. We're not sure what it is. It's possible there might be some kind of a viral infection that triggers this. My niece suddenly became insulin-dependent diabetic during her first year of college, and 3 weeks before had flu. And then 3 weeks after flu, she was in the ER with a blood sugar of 525. Whether that's related, whether it was bound to happen anyway, who knows? But we're still looking at what can trigger this. It does happen, it can happen quickly, although it may be a while before those symptoms are truly recognized as diabetes. Kendall, for example, was treated for mono. Although they never tested her for mono, they were treating her because she had some of the symptoms until her mother just brought her into the ER. Okay? Type 2, there is insulin produced, but for some reason it's not effective. And we think that has got to do with there's some kind of resistance or a lack of recognition. Okay? So there is some insulin produced, and it's produced in a decent volume, but it's just not clicking. Okay? So because of this, there are often different medications. In type 1, we use insulin. In type 2, we tend to use some oral agents, but if the oral agents lose their effectiveness, or somebody's type 2 slowly transitions to type 1, then you see insulin being brought into the picture. Now, why insulin? Insulin allows, when you have diabetes, the sugar that's in your blood cannot get into the cells. The cells rely on glucose as the major source of energy. If the glucose cannot get into the cell, then you have no source of energy and you've got an awful lot of sugar floating around in your bloodstream. Insulin allows the sugar to go from the bloodstream into the cells, where it is then converted into energy, especially for the brain. Okay, so that's the benefit of insulin. At the moment, there is no oral form of insulin. For many years, it was injected only. Now they're looking at nasal insulin, but there is no oral version because gastric acid would destroy it. So this is why for many, many years it was injection only. Although I actually had a patient who injected into the orange and ate the orange because she didn't like injections and she thought that would work. Well, she ended up in the emergency room not too long after that, okay? You guys know the general symptoms. Basically, you have somebody who's very tired, unexplained weight loss, very thirsty, very hungry, urinates frequently and in large volume. Okay, so those are the general symptoms. In terms of the testing that we do, fasting blood sugar is kind of the absolute clearest cut of where their blood sugar is. It needs to be a fast of 8 hours plus. And we do have some ranges there for normal. And then we have some ranges for when they're not clearly a diabetic, but there's some grounds for concern. And that's what we would call pre-diabetic. And that's when you say, you know, did you just eat a whole bunch of candy? What have you been eating this week? So, and then, you know, do you have a history of diabetes? Do you have any other symptoms? So when somebody's fasting blood sugar comes in at over 100 to 125, they need further assessment. When it comes in more than 125, you really need to start ruling in or ruling out for diabetes. What we call point of contact is random testing. That's non-fasting. We do that by venipuncture, but we also do it by finger stick. Okay? Whenever you get a strange reading on the glucometer, you should change glucometers, recalibrate, and then if there's still some concern, then draw a venipuncture and verify it that way. Okay? So point of contact, we like to see no more than 180. Okay? The A1C, okay? Hemoglobin A1C gives us a nice range of how have they been for the last 3 months. So this way my father cannot starve himself or eat healthy for 3 days before his blood gets tested because the doctor finds out. You know, that was his reliability thing. He would just eat healthy before the test. Now the A1C gives my mother a better idea of how badly my father has been eating. Okay? So A1C looks at blood sugar control over about 3 months. That should always be looked at in addition to the fasting. Blood ketones, If blood sugar is extremely high, then we test blood for ketones. But the urine testing that I actually did as a nursing student, and we actually had sliding scale insulin based upon urine testing. You guys, it's not something you'll ever see. Okay. In terms of hypoglycemia, blood sugar less than 70 is going to make somebody start to feel awful. In the ICU setting, this is a major concern because most of our patients in the ICU are sedated, paralyzed, intubated, ventilated. If they feel bad, they don't know it or they can't tell you such. So this is why in the ICU setting, the majority of your patients should be on a finger stick at least 4 times a day, and also have some source of nutrition going through. And then treatment as below. Now sometimes you'll check them and they'll still be looking good, but their blood sugar will be 32. And at other times, somebody will fall unconscious, you check them and their blood sugar is 32. So the tolerance for hypoglycemia can vary, and it also depends how quickly they drop down. But I've seen people talking to me at 32, and I've seen people out at 32. So, when in doubt, verify. Those who can eat or drink, have them eat or drink first. The golden standard is a glass of orange juice with 2 packages of sugar, in addition to crackers with peanut butter or cheese. So you want glucose to immediately get them up, and then you want some kind of a more substantial food, carbohydrate and protein, so that they're kind of achieve a level of steady state. Okay. That's why there should always be food and juice on any kind of a hospital ward. The gold standard for rescue, IV-wise, is D50. But as you know, if you ever have to push it, it comes in a big syringe, 50 cc's, and it's very hard to push, and you cannot push that fast. It also can be very irritating to a peripheral vein. Whenever possible, try to push it in through a running IV, and that way it won't irritate the vein. Hyperglycemia is what you're probably going to see more of in the ICU setting. And once again, these people feel lousy, but a different kind of lousy. And if the patient is intubated and ventilated and kept down with medication, they're not going to be able to tell you those symptoms. Another reason why we do finger sticks 4 times a day plus more in the ICU setting. If the person can tell you how bad they're feeling, what they're going to tell you is going to resemble the undiagnosed diabetic. The higher the blood sugar, the more dehydrated they will be. Okay? With all that blood glucose hanging around in the blood gets very concentrated and has an osmotic pull. So it's going to pull fluid from the interstitial tissue into the bloodstream, making them very dry. Okay? And then if they have a functional kidneys, then they're peeing out large volumes of fluid as well. So the higher the blood sugar, the more dehydrated that they will be. Okay? Here we talk about blood sugar tends to go up following any major stressor, illness, injury, infection, surgery. That's every ICU patient. And so hyperglycemia in non-diabetic patients is frequently seen in the ICU just from the stress of that health crisis. They have tagged that better management of this ICU hyperglycemia leads to better prognosis for the patient. And so you don't be surprised if you see ICU patients for a glucometer, QID, plus some kind of sliding scale insulin protocol. It's for that purpose. Also, a lot of the drugs we use in the ICU and on the step-down units will have a secondary hyperglycemia effect. Vasopressin, epinephrine, norepinephrine, beta blockers, Lasix, they all can increase blood sugar. And steroids as well. We'll talk more about that in a little bit. Insulins, it used to be, I remember the day of regular, lente, and NPH. Now, of course, there's a whole bunch of other options, and that's great. But it's a little confusing to stay on top of them all, so hopefully this chart. Try to categorize them. How quickly do they work? So we have ultra short-acting insulin now. That's your Aspart and your Lispro. And then we have short-acting, and that's the gold standard, that's regular insulin. So that's the equivalent of like morphine in narcotics. It's what everything is compared against in narcotics, and in diabetes care, regular insulin is the gold standard. You'll see regular insulin on your NCLEX. Okay. The nice thing about regular, it's reliable and it's tolerated by most people. It starts within 15 minutes. It peaks within 2 to 3. So basically, if they get it around 7:30, around 10:30, 11, if lunch is going to come up that early, great. If lunch is not coming up that early, they're going to need a snack. Okay. It lasts for a good 5 to 8 hours. Okay. And the nice thing is that it's reliable and it's tolerated. When we talk about IV insulin infusions in the ICU, it's only regular insulin that we use. We don't use any of the others, it's only regular. We have intermediate acting, the classic one of that is NPH. We have long acting, that's Lantus. And then we have some mixed versions, 70-30 is common. The nice thing is we used to have to mix these things into one syringe, now they come pre-mixed. Okay, this just shows you one example of regular insulin. Okay, this is from Lilly. And do you see the big black R on the side? That's the standard sign for regular. Okay, and here you also see regular human insulin. Do you see down here U100? Okay, that needs to match the U100 syringe, which means in 1 cc of volume of insulin, okay, there should be 100 units. They don't have it so much now, but years ago we used to have U50, U100, and U200. We had varying concentrations of insulin, and so we had to have varying syringes that match that. Now all you should be seeing out there is U100, but you need to verify that you're using a U100 syringe with a U100 concentration of insulin. Okay? And you should see it, let me go back here, previous. You'll see it here on on here, and it will be on the vial as well. And then check your syringe. So here we have 100 units in 1 cc. Only insulin syringes should have an orange top. And don't mix up insulin syringes with TB syringes. Okay, good. Okay. Nice thing now, we have prefilled pens. These are really handy, especially patients who have poor dexterity of their hands or poor vision. You can buy these, they're pre-filled, they've got this needle which is reusable, and then you dial up or dial down your dosage. Now this is one version, and so on this version from this company, you dial up and dial down here. But insulin pens from another vendor may have a different type of dial up, dial down button. So look for it, okay? And so this is a pre-filled syringe. It's got a mix, a 70-30 mix. It's got the short needle. The needles are wonderful now. They are thinner than ever, and they are lubricated. So the injection itself, they're going to feel it, but it should feel extremely tolerable, okay? Because these needles are so sharp, so thin and lubricated, so they pass through the skin very quickly. Whether these things need to be kept in the fridge or not will depend upon the vendor and depend upon the drug within. So patients need to be told, your pharmacist will tell you whether this needs to be kept room temperature or kept in the fridge. Okay. These pens, they just go at a 90-degree angle and they pop the end. The needle is activated, the dose is given, they then cap it, and they store it as directed. A lot easier than teaching patients how to draw up in a syringe. Sites, rotation of sites. Do you remember something called lipid dystrophy? If they use one site over and over again, it gets kind of bumpy. So they need to rotate sites. They need to be at least 1 inch away from a previous site. And you avoid areas of rashes, bruises, wounds, hematomas, and scars. Scars are avascular. Okay? Lots of sites they can use, the arms, the thighs, the belly, the butt, the back. They can get to it, like back here, and they should rotate. They should have their own system of rotation. Okay, left arm to right arm, or counterclockwise or clockwise, but a system that they keep to and that works for them. And then we now have insulin pumps, which are remarkable. When I was in the late 70s in nursing school, I couldn't even have imagined that these things would come out. And they really have made life so much easier. I have a cousin on one of these. And so the pumps will look different depending upon the vendor. They usually involve an indwelling subcutaneous needle that will need to be changed every now and then. And the patient learns how to dial this up and down, bolus themselves as needed. At the same time, they're checking their finger stick glucose. Okay? So if a patient comes in unconscious, it would be nice to know if they have a pump in place. Ideally, they should have some kind of a medic alert, but just be aware. Okay? You will always see a question on NCLEX regarding mixing insulin. And hopefully this is just a review, but the question will have to do with you're going to mix regular with NPH, and what do you do? And hopefully you remember it's clear before cloudy. Okay? You don't want to contaminate the regular insulin with long-acting insulin, because in an emergency you're going to grab the regular insulin and you're going to need it to work quickly. So you don't want it contaminated with longer acting. Okay? So regular first. The other term is clear first, then cloudy, because the longer acting tends to be cloudy. Okay? And this one just shows you inject air in and then you pull back. I'll let you guys look at this later on. Okay? Now what you're going to see in the ICU setting, other than that typical ICU hyperglycemia, tends to be two conditions. Both are extreme hyperglycemia. The most common one is called DKA, Diabetic Ketoacidosis. This is severe hyperglycemia. This tends to happen if a diabetic patient has not been compliant with diet or insulin, or they have been compliant, but they've been ill, injured, or under a tremendous amount of stress. Okay. And so that clinical stress is going to make their blood sugar tend to go up anyway because of cortisol release, and especially if, say, they've got the flu over 3 to 5 days, they're at risk for DKA. Okay. These folks deteriorate in level of consciousness. They get very dehydrated. They breathe funny. It's deep and rapid. And they have, that's called Cushing's respirations, and they tend to have a strange mouth odor to them that's been described as fruity. I had a peer in the ICU who used to call it the smell of rotting strawberries. Some people think it smells like, juicy fruit gum. But it's kind of the smell of fruit on the edge, basically. Okay. Okay. What you're going to see is the change in level of consciousness, this deep, rapid breathing, somebody who appears to be dehydrated, and if you can detect this strange fruit-like mouth odor. This is just, physicians learn by mnemonic, and this is just one physician mnemonic for what to do to get somebody out of DKA. Okay? The potassium, the insulin, if they're comatose, NG tube, glucose, once they get the levels back down, monitoring urine output, catheterizing. But let's go through here. DKA does not happen all of a sudden. DKA develops over several hours, maybe over a day or two. Okay? Frequently, it's a patient who's been sick, upper respiratory infection, flu, sinus infection. A couple days, and about day 2 to day 3, they're starting to have some problems. Okay? And what it is that the demand for insulin, because of the cortisol level rising during stress, exceeds the amount of insulin that they've been used to giving to themselves. We've got symptoms down here. Blood sugar goes up, as does potassium, and this is what you need to do, but let's go here. Okay? Diabetic ketoacidosis, blood sugar is more than 250. So my niece was obviously in there. And you see metabolic acidosis at the same time. quick onset here, okay? And just what we've talked about, they will have that appearance of dehydration as well. This is more common in type 1 patients, okay, triggered by some kind of a clinical crisis, which can be stress. Okay. You do look at have they been compliant to treatment. This is why diabetic patients should always, before you let them be discharged, they need a clear understanding of what to do when they get sick. So their sick day protocol, checking their blood sugar more often, trying to eat, staying in touch with their physician as well. What we do in the ICU is we rehydrate them. We put them on insulin infusion. I'll talk more about that in a minute, to get their blood sugar start to go down. In terms of the metabolic acidosis, in many cases, just bringing their blood sugar down and hydrating them will stop that. You don't need to give them bicarb to offset that. Very rarely have I ever seen that done. So just getting that blood sugar down and rehydrating them will overact that acidosis. The most extreme state of hyperglycemia is called HHS. And this is when their blood sugar is over 600. And you'll see it if you haven't seen it already, especially at Christmas time, when people start eating what they shouldn't eat, traveling, getting sick because they've been, in a house with a lot of relatives, or the stress of Christmas. You'll see it probably around late December into January. They are extremely sick, and all their clinical symptoms are the same but more profound. The higher the blood sugar, the worse the hyperglycemia symptoms. But in this case, there is no ketoacidosis. And this version is more common in type 2. Similar treatment, rehydrate, get their insulin down, monitor their potassium, ICU, try to figure out what triggered it, and focus on the trigger. But DKA, we have metabolic acidosis with ketones being released, but in HHS, there is no ketoacidosis, okay? Now, in terms of IV infusions of insulin, should never happen on a med-surg floor. Okay for step-down, progressive care, IMCU, ICU, initially in the ED, but this is not something that should be on a med-surg floor when you've got 7 other patients or 6 other patients. It can be very dangerous if it's not monitored closely. It's regular insulin diluted into infusion, which is administered by IV pump only, and you're monitoring their blood sugar at least once an hour. And every hour, based upon what that result was, you look against your chart, lab result against the chart, and the chart will tell you the amount of insulin per hour that they should get. So you often are adjusting things on an hour-by-hour basis. It's incredibly important that you have a reliable glucometer, okay, one that's been calibrated, one that's working well, and you have no questions with it, because that is what you're going to be basing your insulin dosing off of, is the glucometer results. You don't want to bring them all the way down to normal, because once you turn off this pump, they're going to continue to drop down. So you bring them close to normal, then you turn the pump off, and they will continue to drop down. You also can't bring them to normal within an hour. It's too much of a change. You bring them to normal over several hours. Okay. Once you bring them close to normal, you better be sure that they have some kind of nutrition on board. If they can eat, fine. If they can't eat, then you're looking at some kind of tube feeding. Because if they are not eating and you bring them close to normal and they're going to continue to drop down in their blood sugar, but they don't have a dietary food source coming in, then you've moved them into hypoglycemia. Okay? So you've got to have some kind of sugar, tube feeding, oral food as soon as they get close to normal. This is what a common IV infusion chart looks like. Okay? And you can see based upon the blood sugar values, this is how much insulin, how much regular insulin is given per hour. So you're actually adjusting on an hour-by-hour basis But there are also some other various protocols out there that are more aggressive, and because they're being used as research tools. One example is the Yale protocol. Another example is a protocol that they used to use at Georgetown. Okay, so check the institution you're going to be working in to see what insulin infusion protocol they are currently using, and that's the one that you're going to be following. But the same rule of get them close to normal and then turn off the infusion will still be the standard. Okay? So that's diabetes. Now let's talk about the other diabetes. This is diabetes insipidus. It has nothing to do with the pancreas, okay, and has everything to do with the pituitary and the hypothalamus. In this case, the only thing it shares with diabetes is frequent urination of large amounts and a risk of dehydration. That's the only symptom it shares, and that's why it shares that title of diabetes. But this is insipidus. I remember it that, there's an I in pituitary and an I in insipidus, and that's how I always remembered it. Okay? This has nothing to do with insulin, and this has everything to do with antidiuretic hormone production. When the hypothalamus, the pituitary, and the kidney together cannot control antidiuretic hormone, and so that there really isn't any being produced or secreted, then the kidneys have uncontrolled urination. They don't filter, they don't hold back fluid, they just urinate out as much as they can urinate out. And so these folks get dehydrated, they have massive frequent urination, and because of that drop in in volume, they become hypovolemic and hypotensive. And what you have to do is give them an external source of ADH, and that's a drug called vasopressin. We're going to talk more about that in a minute as we talk about pituitary resection. So the treatment for this is not insulin, but ADH. And the synthetic version of ADH is a drug called vasopressin. Now, when do you see DI? There's an increased risk for anybody with a pituitary tumor, head trauma, or a brain surgery done transsphenoidal. When you hear transsphenoidal, the thinnest part of your skull is actually behind your nose. And what it means is they went through your nose, popped through your sinuses, and went to, behind your sinus is the pituitary gland. So any kind of transsphenoidal surgery, any kind of blunt facial trauma that may break those sinuses may cause it, and any kind of general head trauma. Okay? So this just gives you an example. Okay? The pituitary gland is in control, sends the ADH, the trigger for ADH, to the kidneys. The kidneys pull back water so that they don't excrete all the water in your body. But in diabetes insipidus, that control does not take place, and the kidneys do uncontrolled urination. Okay? So what you have is a dehydrated, hypotensive patient who spends all his time urinating. And the urine is extremely dilute and excessive in amounts. Okay? But their blood sugar is normal. There's nothing wrong with their pancreas. There's nothing wrong with their insulin. Okay? Treatment is rehydration, vasopressin. Vasopressin can be given by injection, but most commonly it's given by a spray, a nasal spray. And we'll talk more about that when we talk transsphenoidal pituitary resection. Closely monitoring them and trying to figure out what caused this, and then focusing your attention on the trigger. This is vasopressin, DDAVP, and they just take the cap off and spray it up. Okay. And it works pretty well. It works really well. It's been around for a while. Okay. This is a picture of transsphenoidal surgery, frequently done when there's a benign pituitary tumor. And you see they go through your nose so that there's no opening in your skull. It's done through the back of your nose, cracking through the sinus. And they go after a pituitary. So here's your back of your nose into the sinus behind your nose. They punch through, and then they get the pituitary that's right there. It's done with a combination of ENT and neurosurgeons, done under general anesthesia. It's been done for years. I don't know if you've had a patient yet. They come back, they have to be sitting up, and they have a drip pad. They take a sterile 4x4 and they roll it, and they put it under the nose and then tape across like a mustache. The other name for the nasal drip pad is the mustache dressing. Okay? And the nose is packed, and then the mustache dressing is put over the upper lip. And then they don't have to come back into an ICU, but probably a step down or a busy surgical unit. And they recover quite well, but they need to be watched for diabetes insipidus for several days before they're sent home. You can have partial pituitary resection or total pituitary resection. The risk for DI is going to be correlated to how much pituitary did they take out. If they took the whole pituitary out, then it's going to be a risk. Okay? You don't take the nasal packing out, only the surgeon does that. But nurses do change the drip pad. And when we change the drip pad, we're looking for cerebral spinal fluid. I'll show you a slide that looks like that. Okay? And these folks, because the pituitary is taken out, if a total resection is done, they're going to need lifelong steroids and Synthroid, and possibly vasopressin. Sometimes the body adjusts to live without the vasopressin, but initially they may need that. This is what the drip pad looks like. Okay? It's just rolled up sterile 4x4, taped across. Okay? When they come back, okay, it's general post-op care with Neuro Checks, monitoring urine output, monitoring vital signs, head to bed up. You don't want them doing anything that's going to blow that patch. Where they punched through, they'll try to put a bone graft back there, but they'll also take a piece of muscle, usually from the thigh, to patch it. And they're patching that puncture site so there won't be a CSF leak. Your biggest concern is that they sneeze, cough, vomit, Valsalva, anything that's going to dislodge that muscle patch, and then you're going to have CSF leaking from the brain through their nose. So you want them quiet, antiemetics if need be, cough syrup if need be. Okay? They're not to bend over, they're not to pick anything up, you don't want them straining at stool. You want that muscle patch to kind of grow in place there. You also don't want them brushing their teeth. They can use those swabs, which taste awful, those lemon glycerin things, but you can dip those into a mouthwash and they can swab their teeth, but you don't want the rough vibration of them brushing their teeth. As nurses, we're going to monitor for pain. They should be quite comfortable, actually. Percocet or two should do them fine. If they start complaining about a massive headache, then you get concerned. If the drip pad is constantly saturated, you get concerned. And if their urine output becomes excessive and their blood pressure drops, then you become concerned as well. There is, of course, that risk of infection, and what you'll see is a febrile patient with a stiff neck and a headache. Now, I don't know if you can see this. When CSF leaks onto a piece of gauze, it produces what's called the halo sign. And what you see is a clear center with a yellow tinged outer circle. So when you, and this tends to be an NCLEX question. So when you take the drip pad off, you want to check to see if you have a halo sign on it. Okay? If a patient has continuous clear drainage coming out, they may have them kind of drip onto like a 2x2 or 4x4, and you can see it then. The other thing with CSF, it tests positive for glucose, so dipstick. Okay. It's clear, it does a yellow halo sign, positive for glucose on a dipstick. Okay. Now the opposite of DI is called syndrome of inappropriate antidiuretic hormone. In this case, they have too much ADH coming on, and so, you know, what you have is the elevated sodium and fluids. Okay? This does not happen often, and the few times I've seen it happen, It was an indicator that the patient had a certain form of lung cancer, but that lung cancer had not been detected yet, and that's small cell lung carcinoma. Okay. For some reason, it's an early sign of that. I'm not sure why. I've never been able to find a good reason in the textbooks. Okay. These folks come in with lethargy, nausea and vomiting. They feel lousy, and their serum sodium is sky high. And then they do a chest X-ray on them, and they often see a mass. So the treatment of this is focused on getting that sodium level back down. Remember, if your sodium goes too high, you seize.
Sorry, on the last one, you said it was
Hold
high
it.
sodium?
Let me look here. Oops, let me go back up. Let me go back to here. Okay. Oh, sorry. It's actually with sodium, seizure risk is with extreme low sodium and extreme high sodium. Okay? So let's go back to what I've got here. Those previous. Okay. All right. Yeah, let me double check that too. But you're going to have, when you have too much antidiuretic on board, antidiuretic hormone on board, the kidneys won't pee off any water. You retain it, and it will dilute your sodium level down. Okay? But seizure risk with sodium is extreme high or extreme low. Okay? Did that clarify things, or did I lead you further into confusion? Okay? With too much ADH, you hold on to the water and you drop your sodium. Okay? And so how you bring sodium level back up, you could give IV infusion of very concentrated sodium, but that can quickly put people into fluid overload too. What you tend to do is do low sodium diet, low dietary sodium, and severe fluid restriction. And over a day or two, the sodium level comes back into balance. Okay. All right. Let's talk about adrenals. The adrenal glands. They sit on top of your kidneys. There's one on each. You have an adrenal cortex and you have an adrenal medulla. They're two separate sections of the kidney. Okay. We talked a little bit earlier about pheochromocytoma, and we'll do a little bit of that, but most of what we'll talk about is Cushing's and Addison's. If you take the adrenal gland aside and you cross-section it, the inner part is the medulla. That's where your catecholamines are produced. The outer part is the cortex, and that's your glucocorticoid steroids come from that area. Okay? Two diseases that you'll see. And then there's Addison's, there's Cushing's. But more what you're going to see in practice is not Cushing's disease, but Cushing's syndrome, which is the side effect of steroid therapy. Addison's disease is when the adrenal glands don't produce enough hormones, in particular the adrenocortical steroids, okay? Cortisol and aldosterone. You need those for just daily life, and you need more of them in any kind of a stressful crisis. So, adrenal insufficiency, otherwise known as Addison's disease, can be life-threatening. People can coast through it on an average day, but the minute the day becomes stressful, or there's illness, injury, surgery, that's not good enough, and they go into a crisis. Can be primary or secondary in nature, and the amount of the intensity of the symptoms will correlate to how much of a hormone deficit there is. There are some people that are just low, and then there are some people that have hardly any hormones being produced whatsoever. So symptom intensity varies depending upon the degree of deficit. Okay? What you see is a very hypovolemic, hypotensive patient who's anemic. Blood sugar is low. Their electrolytes are all messed up. They feel lousy because their GI tract is acting up, and everything is either tired or sore. The other trick is they tend to have problems with skin pigmentation, either patches of vitiligo, which is pigment loss, or they have a tan, an inappropriate tan, which is not from the sun, It's not from a spray tan or any kind of a tanning. And it's got more of a bronze nature and color to it than what a normal tan would have. Okay. So we've got a dry, hypotensive patient with GI issues who's tired, muscles and joints ache, electrolytes are all messed up. Okay, and then that bronze pigmentation. Okay. Now the classic is John Kennedy. John Kennedy was diagnosed with Addison's when he was in his 30s. And what we thought looked like a very healthy, young, good-looking president was actually an incredibly sick guy. People said he was lean and he looked tan. He was lean because he had Addison's disease, and he wasn't tanned. He had hyperpigmentation from Addison's disease. But at the time, that was kept secret because he was the first Catholic president. There was some reports that his father may have had some dealings in the election process, and he didn't want to call attention to himself with characteristics that may not have been pro-president. So his medical history was pretty much a secret and classified until after his death. Diagnosed in 1940, he was 30 years old with Addison's disease. However, he had lifelong symptoms of a troubled stomach, weakness. He was always sick. He was always being pulled out of school for illness that nobody could figure out what was going on with him. He was later on, 15 years later, diagnosed with hypothyroidism. The belief was that he had an autoimmune disturbance that affected both his adrenal glands and his thyroid. Turns out he wasn't the only one in his family. He had several siblings, most notably his sister Eunice, and his son John Jr. also had problems with autoimmune thyroid disease. He was put on a secret dose of injections of steroids that he gave to himself for the rest of his life. There is some reports as he was on the election trail of him being seen injecting himself through his trousers into his thigh and giving himself some extra injections when necessary. So he kept all of this secret. He didn't want there to be any reason for people to say he would not be a good candidate until, well, this caused some people to be concerned. He busted up his back in World War II, had a chronically protruding herniated disc, which was operated on in New York, and he almost died during that surgery because nobody knew he had Addison's disease, and they didn't give him that extra boost of steroids needed to cover the stress of surgery. So he immediately went into shock and came close to dying, did have the last rites given. He did not tell the surgeons he was on steroids. For some reason, his personal physician didn't either. And so that caused this horrendous crisis in which he should have died. He was the first person, historically the first person documented to have survived major surgery without a boost of extra steroids. And how he did it, nobody really knows. This is a famous picture of him when he was finally released from the hospital in New York and flown down to recover in Florida. And really, he was pretty much a mess under a blanket. He was still hypotensive. He was still a mass. His electrolytes are all off, and he had a massive wound infection because he was put into an adrenal crisis situation. Okay. In terms of what you need to remember is any patient who needs steroids is going to need more steroids during a crisis. Okay. Be that a patient on steroids for asthma, for COPD, for Addison's disease, for cancer, for transplant surgery. Okay? So not only are we worrying about the people that we know have adrenal insufficiency, but anybody else who lives off of steroids will also need that boost called the stress dose during illness, injury, infection, and surgery. Okay? Once your adrenal glands stop producing these steroids, you will need lifelong replacement plus the stress dose. Commonly, we use a glucocorticoid. That's either prednisone or hydrocortisone, and then a mineralocorticoid, I can't even say that right, fludrocortisone. Okay? So there should be a mixture of both. That should cover the bases. Then they need to have their glucose monitored. They need to be aware they're at risk for infection. They need to have their electrolytes monitored, and they really need a medical alert ID. Okay. There's a common steroid replacement drugs: hydrocortisone, prednisone, Decadron. Okay? And dosages. These things are brutal on your stomach, should always be taken with food. And I don't know if you've ever been on steroids, but they give you this strange sensation that you're just manic and, wild at the same time. They're not very pleasant to be on. Lots of side effects of steroid therapy. Hopefully you guys have heard about some of them. Steroids are immunosuppressant, so these folks are increased risk for infection. Wound healing is poor. Skin becomes very thin, so it tears easily and it doesn't knit back well. They tend to have edema because steroids promote sodium retention. Your blood sugar goes sky high. Your mood is awful. Okay, you get very moody, emotionally labile. You can't sleep. You don't like how you look because your face gets puffy. And then you develop kind of a pad on your back. Your stomach is also, it feels like it's raw and somebody's just cut it open. Okay, and folks can get quite depressed. And I have seen inflammatory bowel disease patients that were near suicide because of the steroid dosage that they were on, so high. Can also cause cataracts. So they're not friendly drugs, that's for sure. They come in handy, but they're not really user-friendly. Okay. When somebody goes from adrenal insufficiency into adrenal crisis, it is life-threatening. This tends to be the patient on steroids who did not get the stress dose or was in a crisis like a motor vehicle accident, had no medical alert ID, brought into the emergency room, and nobody knew that they were on steroids. You can also see it in cancer patients in which steroids are part of their immunosuppressant treatment and their cancer situation worsens. One of the worst cases I saw was a 26-year-old with ovarian cancer. And that was really, I don't know how she survived it. Okay? Sometimes mortality is poor even with treatment, but these folks are severely hypotensive, the potassium level is sky high, and their blood sugar is hard to get back up. Okay? Definitely an ICU situation. You're trying to get as much steroid in them to recover, but you're also dealing with an extremely high potassium level. So, you're worried about their heart at the same time. Okay? So, you've got to rehydrate them, you've got to get steroids back into them, and you don't know how much, you just keep giving it to them in increments until you start seeing some improvement. You got to manage the potassium level, try to figure out what caused this, and be careful of their heart in the process. One of the things that you need to do is do emergency reduction of their serum potassium. And I don't know if you guys have heard about this trick, but this is commonly done in adrenal crisis. It sounds weird and it sounds really risky, but it works beautifully. It should only be done in an ICU setting though. And you have to time these medications perfectly so that the patient doesn't go in crisis. But you do like 3 or 4 major things. First, you give K-Exolate. K-Exolate is going to rid the inside of the GI tract of anything that has potassium in it. So if there's potassium food still inside the GI tract, the K-Exolate is going to push it out. So whenever you give K-Exolate, expect a patient's going to have severe diarrhea because of that. It works quickly. But you also have to worry about the potassium that's circulating already in the blood. You've got to somehow bring that down quickly. So you use insulin, because when insulin pushes glucose into the cell, it also pushes potassium into the cell. So you give them insulin. But if they are not diabetic, then you risk hypoglycemia. So you have to recover them with some kind of a glucose as well. So you give insulin and then you give D50 at the same time. So that's going to take a good chunk of serum potassium out of the picture, push it into the cells, and you'll deal with that later. You're still left with some potassium left in the blood, and you use a diuretic like Lasix to get rid of that amounts still left in the blood. So it sounds pretty risky. It is, but it works beautifully. Okay? So the K-oxalate, the insulin, regular insulin, the D50, and the diuretics. Okay? Will quickly bring that very, very high potassium back down. I think we've gone over this. Anybody on steroids needs more steroids in crisis. Anybody on steroids should never all of a sudden stop taking the steroid. They need to be weaned off at least over 3 days, if not longer. That will depend upon how high a dose they're on and how long they've been on that dose. Okay? So they should never stop. They should always be weaned off, and they should always have a stress dose in a crisis. So keep calm and stress dose. And we're seeing a lot of this lately. Please check anybody, especially in the ED, please check them for adrenal crisis. Okay. Cushing's disease is a disease in which too much adrenal hormones are produced. Too much steroid is being produced by the body. It's quite rare. More commonly, what you're going to see is Cushing's syndrome. So what happens when they are on steroids, either high dose or too much? Okay? There's a lot of variations of Cushing's disease. You don't see the pure form very often. The treatment depends upon what is the cause and what form of the disease that they have. Once again, more often what we're treating are patients who've been on steroids for a long time or at a high dose. Okay. Cushing's syndrome. This is what we talk about with patients that are on steroids. Over time, they will start to develop some side effects that are usually unwanted. Personality changes, definitely. They can go from emotionally labile to irritable to insomnia to absolutely psycho. Okay, hallucinating and everything. Blood sugar can go sky high and require medication just to control the blood sugar. The face becomes puffy and round. That's called the moon face. Increased susceptibility to infection. Their fingers get puffy, their ankles get puffy because they're retaining sodium and water. The skin becomes pale, translucent, and fragile. And on the elderly people on steroids, you see a lot of skin tears and bruising. Okay? The stomach, the steroids are brutal on stomachs. So they can have gastritis, they can actually develop an ulcer. Okay. You can see these purple striae on the legs, on the stomach, on the back, and as I said before, easy bruising. Steroids long term will cause bones to become extremely brittle and break easily. They also cause something called avascular necrosis of the femoral head, in which the top of the femur, that ball in the ball and socket of your hip, just crumbles. Absolutely crumbles. It loses its vasculature, it loses its perfusion, and just crumbles, and these folks need a total hip replacement. Okay. You turn somebody to the side, you'll see this hump that develops, not between the shoulder blades, but slightly above the shoulder blades. And what you see is somebody who has thin extremities, but a larger central torso. Okay. This is just one effect. This child was put on steroids. This is the child normally, and here you see that moon face. Okay. This is not politically correct. However, it may be easier for you guys to remember. Somebody sent me this. Okay. The 7 dwarfs of Cushing syndrome: forgetful, chubby, bruisey, sleepy, hairy, angry, and psycho. Okay, if that helps you to remember it, so be it. All right. And then we're going to talk about thyroid, okay? Hyperthyroidism, it's also called thyroid toxicosis, in which the thyroid gland produces too much thyroid hormone. Your thyroid gland is like the engine of your body, and so when there's too much thyroid hormone, the body is revved up, basal metabolic rate goes up, heart rate goes up, you're like revving for action there. And you have an increased sympathetic nervous system response. So BMR is basal metabolic rate. SNS is sympathetic nervous system. We see this in women between the ages of 20 and 40, And then once you cross the line into 40 to 60, we tend to see hypothyroidism. Okay? Most common version in the United States is something called Graves' disease, which is an autoimmune version of hyperthyroidism. So when they actually test your body, they can see the antibodies associated with Graves'. For some reason, antibodies are triggered to attack the tissue in the thyroid gland. And in response, during Graves' disease, some patients, the thyroid cells become defensive and increase in size, and that results in something called the goiter, which is this kind of enlargement, this bulky enlargement at the base of the neck, and I'll show you pictures of that. The size of the goiter does not mean more thyroid is being produced or less thyroid is being produced. All it is enlarged thyroid cells, okay? But it can get pretty unsightly. In most cases, Graves' disease is caused by an inflammation of the thyroid, and the autoimmune version is called Hashimoto's thyroiditis. That then triggers the resultant Graves' disease. And Hashimoto's was the first autoimmune disease to be diagnosed. Just picture somebody whose body is completely over-revved. Tachycardic, a little bit hypertensive, insomniac, hot, sweaty, just, over-caffeinated, shaking, okay? All right. Lots of symptoms. One of the biggest clues is that they don't tolerate heat. They can't sleep, they feel awful, and they're feeling hot all the time. Those are the biggest clues, okay? Here's your thyroid panel. So their thyroid hormone levels are up, okay? But everything is raved up. They're hungry, they're losing weight, they can't sleep, they can't settle down. This is goiter. Okay. It doesn't mean that more hormones being produced. It's just enlargement of the thyroid. Okay. Now, Graves' has this other sign to it. So there's various versions of hyperthyroidism. What we see a lot of in this country is the Graves' version. And unique to Graves' are these bulging eyeballs. And they are quite protruding. In the most severe form, the eyelid, when closed, cannot cover them. And they're not comfortable. The eyes hurt, they're sore, they feel like there's a lot of pressure in there, the vision is blurred. So it's not just a cosmetic concern. There's comfort and there's vision as well. Okay. Barbara Bush had this. And let me go into, there was a period of time just about the changeover when he went from vice president to president, and they moved out of the vice president's house and moved into the White House, that she was diagnosed with Graves' disease. And the symptoms went on for some time. She was a tall, large woman who always found it difficult to lose weight, and all of a sudden she lost 20 pounds without trying. She was also having trouble with her eyes, kept going to the eye doctor saying, these glasses don't work, these glasses don't work. And her eyes felt dry and sore. They did work her up and determined that she had Graves' hyperthyroidism. In her book, she just says, my thyroid went wacky. They put her on some drugs, Tapazole to offset the high thyroid, steroid because Graves' is autoimmune, and they ended up having to do radioactive iodine on her to destroy her thyroid to stop this hyperthyroidism. About the time she was getting better, the husband then got sick. He passed out while running in D.C., determined to have an arrhythmia, and when they brought him up to Bethesda Naval and checked him out, he too had Graves' hyperthyroidism, but his prominent symptom was more the cardiac arrhythmia. And at the same time, the dog came down with it as well. So they ended up doing this total assessment of the vice president's house and the White House, wondering, was there contamination, what was going on, what was the radon level. They never did find out why the three of them all came down with thyroid disease at the same time. General treatment, the engine can't stay revved up all that time without some damage, so you have to protect the heart, bring the heart rate and the blood pressure back down. You monitor, in hyperthyroidism, you monitor the temperature very, very carefully. Because the most extreme form of hyperthyroidism is thyroid storm. And the most deadly part of thyroid storm is its extremely high, life-threatening fever. I mean, we're talking 105. So when you start to see fever, low-grade fever in a hyperthyroidism patient, that's great concern. They like to have a cool room. It helps if they sip on cold fluids. If they have bulging eyes, the artificial tears. And then they're put on medications to either decrease the hormone production or destroy the thyroid gland totally. In the most severe form, you surgically take out the thyroid gland, and that's called a thyroidectomy. Okay? These are the three types of pharmaceutical treatments for hyperthyroidism. One is the iodine preparations. What you're probably going to see on your NCLEX are these two, Lugol's and saturated solution of potassium iodine. Okay? They are oral elixirs, and they cause the thyroid to stop producing. Well, it produces, but it can't release the thyroid hormone. Okay. And it decreases the vasculature of the thyroid at the same time. This is always done before surgery on the thyroid, because when they operate on your thyroid, they're going to manipulate that thing. And while they're moving it around and squeezing it, they're going to release extra thyroid hormone. So if you give them this treatment before the surgery, you reduce the risk of a thyroid storm during surgery. Okay? So Lugol's and SSKI are given to reduce production release of the thyroid hormone, and always given pre-op. The next thing are the thionamides. These are medications that block production. The most common one is tapazole, but you may also see PTU. Okay. Got some side effects to it. Okay. And you can give too much and throw them into hypothyroidism. When these two don't work, then you go to the middle, and that's radioactive iodine. It's iodine 131. It's a radioactive solution they drink, and it destroys the thyroid cells, so the thyroid cells are permanently destroyed, which means that after this, they'll always need to have thyroid hormone replacement. This is what was done to Barbara Bush. George Bush didn't need it, but Barbara did. Okay? So for a couple days into a couple weeks, they are actually radioactive. Their body fluids will be radioactive. Okay? They may need 2 doses. Barbara Bush needed the full 2 doses. And you still have to treat them because the full thyroid destruction may take 6 weeks following the iodine, the radioactive iodine. So you may have to have them on medication until that 6 to 8 week. Precautions for iodine 131. Okay. This can be done on a med-surg unit, but a med-surg unit that has an end room that has a thicker wall and ideally steel in the wall. Okay? You just can't do it in a room near the nursing station. And these are the guidelines that they're told. Their body fluids will be radioactive until that stuff is released out. They need a private bathroom, so when they go home, they have to have their own bathroom, and they flush 3 times, and they sit to pee and avoid incontinence. Okay? Their clothes, because it will be released through sweat, their clothes need to be washed separately from other family clothes. And after they wash their clothes, the machine should go in an empty cycle to clean the machine. They are given laxatives to push the radioactive food remnants out of the GI tract. They eat with paper plates and disposable utensils that are double bagged. No sharing of cups, of eating utensils, of toothbrushes, and they need to avoid small children and pregnant women. Barbara Bush in her book says the worst thing about it was she couldn't pick up her grandkids for 6 weeks. And she had to stay away from her grandchildren. Okay. All right. Thyroid storm. This is a big concern about hyperthyroidism. It doesn't happen often, which is fortunate. It's hard to pull somebody out. It's excessive, uncontrolled production of thyroid hormone almost to the point that the body burns out. becomes almost like a burned out light bulb, okay? Life-threatening even with treatment. It can be triggered, and the triggers are there, okay? What you see is extremely high fever, tachycardia, arrhythmias, and hypertension. So the engine of the body basically burns out is what's happening. They can become comatose and they can also seize. Basically, you want to cool them down, you want to slow them down. And you want to then find out what the trigger is and try to get the thyroid gland from producing more. So ICU setting, intubate, ventilate, cool. You're using a cooling blanket. You're turning the room down. You've got ice pack to groin, neck, and axilla. You may actually be doing iced irrigation through the Foley. Okay. You need to keep them hydrated, so IV fluids. These are your agents for counteracting thyroid production. Beta blockers to reduce heart rate. You want Tylenol for fever. And then, cool them down, slow them down, and try to find out what's going on. Thyroidectomy, if there's no other option, or there's a concern there may be cancerous cells, the thyroid gland is taken out. The incision looks like this. It's at the base of the neck, in the front. Usually 2 Jackson Pratt drains to self-suction. The incision's there. Here's your thyroid gland wrapped around your trachea. If it's being done for hyperactive thyroid gland, they will pre-treat the thyroid so that when they manipulate it during surgery, they're not going to cause release of more hormones. You don't need to do that if the surgery is being done for question of cancer. But if there's any hyperthyroidism, you've got to treat that so that they don't go into thyroid storm during surgery. Okay? If the majority of the gland is taken out, they'll need to go on thyroid replacement. The biggest concerns are these two. They can nick the laryngeal nerve. Okay. They can take out the parathyroid hormones, sending the patient into a very severe hypocalcemia, or they can cause swelling of the neck or hematoma of the neck so severe that it compresses the trachea. So those are the 3 big things you worry about in a thyroidectomy: the laryngeal nerve, which affects speech, the removal of parathyroid glands causing them to go into hypocalcemia, and what's called the anterior neck syndrome. Okay? So when you talk anterior neck precautions, means you're monitoring these people. They're in the ICU, they're up front, they're sitting in a way that you can watch their neck at all times. You're going in, you're looking how swollen is the neck. Do I see bruising? Do I see development of a hematoma? Can they breathe okay? Is their airway open? And you always have a tracheostomy kit and an intubation kit nearby. Knock on wood, I've never have had to do an emergency trach or intubation on a thyroid patient, but it can easily happen. And I do know at Inova Fair Oaks, when I was executive over there, they did have a case and she died. They couldn't get to her quick enough. Okay. You want to do anything you can so that they do not rip that incision open. So you want them more chin to chest than hyperextended. No coughing, no sneezing, no vomiting. If they rupture that incision, they'll bleed around that incision, develop a hematoma, occlude their airway. We'll just cover hyperglycemia. And then I will record a short thing on mixed edema. Okay? The hypoglycemia that occurs is because they've actually accidentally or intended taken out the parathyroid glands. And what happens is these people become tetanus. They become very irritable, their nerves become irritable, and in its worst shape it can lead to seizure and a jaw lockdown with airway obstruction. So to monitor them, you monitor their serum calcium closely, you replace it as needed, and you do 2 assessment tests, Schwastek and Trousseau. Do you remember those? Okay, good. All right. Schwastek, remember C in Schwastek? C in cheek. You tap the cheek, and if the mouth pulls up, they have a little bit of tetany, You've got to check their serum calcium and replace as needed. Okay? The trousseau sign is you put the blood pressure cuff on and they form the C. Okay? And this is normal, and this is a positive trousseau. I'll tape this. You guys have had enough. Okay? All right, I'll hang around. Those who want to look at their tests, I'll be in my office for a good half hour, and I'll narrate the hypothyroid. There's only a few slides. I'll narrate them. Yeah, attendance sheets up here, please. And if anybody from Pedro Hernandez's clinical group, he's left you something, and if you come on up, I'll give it to you. If you're part of Pedro Hernandez's group at Virginia Hospital, he's left you all something. I don't care. Yeah.
Is this the sauce the girls want to play out with? Oh my god. One of them will play. Right? So you have a good rest of your day.
Yeah, I have to go to class.
What?
What time is it? 3:20. Ethics.